Mic number 2.
Marty Markowitz from the Aaron Diamond. The reinfection rates are somewhat stunning, and I just wondered, in the U.S., it's very difficult for some parts of the population to access treatment, and other parts have ready access. Other parts of the population have ready access. How do you handle reinfection as far as getting access to a second course of therapy? I mean, do you get to the back of the line, so to speak, or if you have insurance? Or how does that work?
Yeah, so that's a very problematic area because the first thing is that currently all guidelines for treatment of acute hepatitis C only recommend PEG and ribo therapy. So our possibility to treat during acute hepatitis C are limited, although the response rates to PEG and ribo are very good. They're on average above 80%, so much better than in chronic infection. People are not wanting to be treated with PEG-related interferon anymore, obviously, with the availability of these drugs. So the uptake of acute hepatitis C treatment which was like around 60-70%, has dropped to almost 0%. Very few patients now undergo treatment. That means that we're sort of enriching the pool of people who can transmit, and so that's a huge issue. In the German context, once it's chronic, and the point obviously you have when you counsel a patient is, I say, let's say you diagnose acute hepatitis C, you wait 4 weeks whether the patient clears spontaneously, then he's already at week 8, 9, 10 of his infection. If I treat him with interferon ribavirin, it takes 6 months. If I treat him like early, probably get away with 8 weeks, I'm going to be finished with my DA therapy prior to him ending his hepatitis C therapy with interferon. That's why but that means that the pool of new infections is obviously enriched. And so what we do is, because we have no limitations, chronic hepatitis C is the indication for reimbursement, and no one says in the label that only counts for the first episode, so we treat the patients. The question is, what do you do if you have someone who comes with a second, third, and I tell you, like from my clinical practice, so I treat someone, he's negative at end of treatment, he's negative 12 weeks after therapy, and then he comes 4 weeks later. I was a little confused because I thought, why, we just did our SVR, why are you coming? He said, oh, I don't know, I thought you said I should come again, and then I measure and he has a new infection. So that's 16 weeks after stopping therapy. Then it becomes complicated because how often are you going to treat him per year, right? And that is, I think, where you need to talk. So, and I said, well, are you willing, is there any way we can work on this? Is it your partner? So there's a group of people, they do sex bank parties, and it's always a different group though. So it's not enough to say, well, just treat his 6 best friends, no. And that makes it complicated because he's not willing to change anything. So that is like 2 treatments per year, and I think that's sort of, and then you get sort of like, you say, well, we'll just let it go. But that means that this person will transmit to others, and so there's no good resolved issue. It's just like very difficult how to handle that.
Okay, speaker number 3.
Two questions. One is, this is Bob Grant from San Francisco, both related to hepatitis C. One question is, in the interest of making therapy as simple as possible, is an assessment for cirrhosis still required to initiate hepatitis C? It looked to me like, except for in the case of genotype 3, the SVR rates were similar, regardless of cirrhosis stage. So do we really need that extra step, which obviously creates complications and costs and takes the therapy out of community-based organizations and puts it more into specialty centers? So that's one question. And the other is, what are the prospects for a hepatitis C vaccine? The spontaneous resolution in a portion of people who acquire infections suggests that protective immunity may be possible. Do we know what the correlates of immune protection are for hepatitis C, and could there be a simple subunit vaccine that would be possible here?
Yeah. So you want to answer because it's
okay. I'll answer the first question. As far as treatment regimen is concerned, probably not really necessary. But then actually, if the patient has got significant cirrhosis before treatment, I think one should definitely follow up the patient for screening for HCC. I think this is an important aspect. So I still think one should definitely try to rule whether the patient's got significant fibrosis. The risk of HCC is reduced, but not to zero.
Yeah, so let me add in the context. So first of all, the guidelines obviously say that everyone now has an indication regardless of fibrosis stage. So you're right, I think it's not a mandatory test for saying, is this patient going to be treated or not? The reason why in the EASL guidelines there still is this prioritization is obviously, it depends on your epidemiology, right? So if you're in Spain and you're in charge of a co-infection clinic, you may have 2,000 patients, and you're not going to be able to treat 2,000 patients at the same time. So there has to be an allocation of resources, and obviously that is driven by fibrosis stage. So I think most countries are doing fibrosis stage assessment predominantly to follow a prioritization in who are they going to treat first. In a country like Germany, where the prevalence is low, 15%, so if you have a large HIV clinic in Germany, you have maybe 1,000, 1,500 patients. It's not too complicated to treat 300 patients at the same time. So it's different depending on which country you're coming from. I think the most important point, though, and that's what Professor Lai just, I think, very nicely brought forward, is that particularly in the setting of ID doctors, the patient who has cirrhosis really needs a complete different management. And unfortunately, we often see patients who never had a fibrosis stage assessment, and when they come, they have advanced cirrhosis, and they already have hepatocellular carcinoma. And then obviously you really messed it up because you missed that altogether. So I think it's very important to remember that every patient who has cirrhosis requires not only HCC screening, but also upper endoscopy for checking for varices. So there's a real management, and that's why ID physicians have to work with hepatologists, because there are elements in hepatology which are very important, and then obviously you also have to think of preparing a patient for liver transplantation. So that is, I think, essential, that fibrosis stage assessment is important for general disease management. Your second question with regard to hepatitis C vaccine, I strongly believe that hepatitis C vaccine would make perfect sense, because the MSM outbreak is never going to be controlled by behavioral measures alone. That's at least my personal fear, also in the context of IV drug use. So obviously, if we would have a vaccine, that would be fantastic. And I completely agree, if there is immune response which is capable of, and that is innate immunity, that is CD8 responses, and we can now very well describe who is able and what kind of immune response you need to clear hepatitis C infection. So I think there is hope for a vaccine. There are groups who are working on that, and so I think there's a first trial actually in the Johns Hopkins group, which is currently on its way. So there are at least attempts. As all vaccine, that's not going to be easy, but I think we should really invest and put efforts into that, because I think for IV drug users, MSMs, prison settings, a vaccine will remain very, very important.
Prof. Praban? I'm sorry, you first.
This is Professor Dr. Alok Hemal from India. My question is, what is the prevalence of HIV-2 in Asia-Pacific region? And secondly, have you come across the hepatitis and HIV-2 co-infection?
Yeah, so the prevalence of HIV-2 is very, very low in Europe. It's found obviously more prominent in Africa, and also in certain European countries like Portugal. They have a relatively large HIV-2 infection group, which has some ties, though, to their former colonial states in Africa. These are all, at least to my knowledge, populations which do not have a high prevalence of hepatitis C. So I personally have never seen anyone with HIV-2 and hepatitis C.
Next question, Prof. Praban. Yes.
Prapan Panupak from Thailand. I have a question, Professor Lokarini. Is there any benefit of adding 3TC or FTC to tenofovir for hepatitis B treatment? That's question one. The second one is for pregnant women with hepatitis B positive during ANC. Is there any indication or any attempt to use tenofovir or tenofovir plus FTC together with a vaccine or even hepatitis B immunoglobulin of newborn in order to eliminate hepatitis B transmission?
Sure. There have been a number of studies now of tenofovir being used in high viremic pregnant women. viral loads greater than 10 to the 7, and certainly the introduction of tenofovir after week 32 has been shown with a very effective reduction in mother-baby transmission when only vaccine is used prophylactically postnatally. So I don't think it's become a recommendation yet, but it's certainly emerging from expert practice that that's actually the way to go forward. It'll be interesting to see what the clinical practice guidelines come up with in the next version. So there's been many studies, probably 4 or 5 now, that have conclusively established that. So I think, but that brings up the question about antenatal screening at week 32 for HPV DNA assays are not widely available in areas where mother-baby transmission is still a problem. So we're still trying to grapple with how to best assess that particular issue, because the overall risk is 10% with a high viral load mother in the presence of vaccine alone. So that's going on. In terms of, yes, there's one study that Henry Chan did here in Hong Kong looking at so-called immune-tolerant patients, where he compared Truvada with Viriad, and there was a better antiviral effect in terms of DNA reduction. But even in that, even with Truvada, there was still viremic patients at the end of, I think he went out to week 3 or 4 years, I think. So I was just having this conversation last night that I still think there's a need in hepatitis B to get more potent nukes, even though the companies don't seem to have much enthusiasm for that. Though with TAF looking very promising in hepatitis B, do we actually now go to Descovy and try a study of that? Well, I think that discussion has started with Gilead, but hopefully it'll eventuate in a clinical trial. I believe that we do need to get much more potent drugs in that first 48 weeks. I mean, 48 weeks treatment in e-antigen positive patients and still 30% of viremic, I don't think is very good. Yet where the field is accepting that, and I think we can do much better.
Yeah, we did a co-infection study where we compared patients on Truvada right from the beginning to historical controls who only had tenofovir. So to see whether the addition of 3TC or FTC in that context made any difference in so-called endpoints of hepatitis B therapy, which would be liver enzyme normalization, HPV DNA normalization or negativation, and HB antigen seroconversion. There was no difference. So, and that's why in the guidelines, although we always say give both drugs because you treat HIV and hepatitis B at the same time, there's no evidence, at least from the co-infection trials, that actually adding the FTC or 3TC adds anything in making endpoints look more favorable over time.
Yeah, I mean, I think I don't know about in HIV, but in hepatitis B, there's a huge disconnect between what we see in terms of viral load log reduction peripherally to what actually happens in the liver. There's only a 2 log reduction in the liver in terms of intrahepatic DNA when in the face of a 9 log reduction in the peripheral compartment. So I think that we're probably measuring the wrong thing. And also in terms of your endpoints, most of these studies only go for 1 or 2 years. And I think to try and sort of get a better handle on what's actually happening in terms of the long-term history of hepatitis B is inadequate. And the other point I'll make is that we do not have an ultra-sensitive HPV DNA assay in hepatitis B. They cut out of 20 international units per mil. Now, that's still a huge amount of HPV DNA bubbling around in the blood. So again, the focus of hepatology hasn't really been, we've accepted the sort of level of reduction as satisfactory, and we're now looking at other targets, and hence the phrase antiviral intensification has become to the fore in hepatitis B. So everyone's going to focus now on the nukes plus the core inhibitors, hoping that that will actually be the next leap forward. But I still think that we just can do pretty well with a couple. I mean, the disappointing thing was that Analogue did a study of entecavir plus tenofovir, but you only did a 48-week study and didn't use an ultrasensitive assay and didn't show a difference. But I think that was, you could criticize the design a bit there.
Yeah, I mean, the co-infection patient population obviously has the advantage that you do have the long-term follow-ups because HIV is a lifelong therapy, and so you see your patients regularly, so you can actually do monitor whether there are differences in the long term. But the problem is that now everyone gets Truvada, so your control group of only getting tenofovir is getting smaller and smaller, and then that's obviously an issue.
Did you do quantitative S on that?
At that time when we did this study, that was not available. We're doing it now, and but my feeling is that there's a group where it just sort of never changes at all. It just remains. So all the other markers are sort of, where they should be, but the quantitative doesn't go down.
Yeah, okay.
Okay. Last question from...
I have a question to Dr. Lei. I'm a doctor of infectious disease, come from China. Patients with hepatitis C and CKD, and his hepatitis C genotype is 3. What kinds of DAA regimen do you recommend? Thank you.
Currently, actually, there are no study exactly on genotype 3 with chronic renal infection. But valpapatir, the drug that the last drug I mentioned, together with sulfoxaflor, they do actually have some proportion of patients with chronic renal failure. So it's supposed to be quite good too. Just 12 weeks.
Okay. Mic number 2.
Yijing Lo from Taiwan. 2 quick questions for the panel. The first question is there any study looking at reduced dose of DAA in treatment of hepatitis C, especially for Asian patients who might have a lower BMI, which can save costs as well? And is there any study or evidence on using DAA on patients with very low CD4 count?
Yeah, so with regard to the low CD4 count, the thing is that in all the clinical trials, patients which were included were on HIV therapy. And so most of them had immune reconstitution. And if you look at the average CD4 count in these studies, it's probably around 500, 600. So there is a lack of patients who have a very low CD4 count. And actually, the best data on low CD4 count comes from the APACC trial, which is not a DA intervention study, was PEG and RIBA, and they had allowed the inclusion of patients who had less than 200 CD4 count if the viral load was suppressed. And there the response rate was actually just as good as anywhere else. So in the setting of low CD4 count and suppressed viremia, I would at least postulate that the chances should be the same, but that I think is something which we would hope, which will bring real life data forward. But even if you look at the German GECKO cohort with the 1,400 patients of those who had HIV co-infection, on average, patients now under therapy have such great CD4 count that you just don't have a lot of data in that segment. So that's really missing. With regard to the lower dosages, I'll leave that to you, but I just want to comment that unfortunately, at least for some compounds like declatosphere, we have seen trials with lower dosages, but that was in combination with samepivir, was one trial Stefan Soitzen presented, and they had much less favorable response rates. So that is, I think, is not so easy. And in the HIV context, because of the lack of knowledge of interaction studies, all patients with BCPIs received a lower declatosphere dosage because it was believed there was an interaction, which then turned out to be only true for atazanavir, but not for darunavir and lopinavir. And there had at least been some questioning whether lower drug levels have actually led to virological failure. So I would be very careful in dose adapting at this point.
So, Prof. Jürgen, so in the case of when we start antiretroviral in low CD4, so when do you suggest to start Hep C treatment? After CD4 over 200 or 300?
Yeah, so I personally, I think that all you need is suppressed viremia. I don't think that CD4 count plays any role in that context. I think all you really want to do is treat HIV first, and when the patient is suppressed HIV RNA-wise, then I think you can just apply hepatitis C therapy, and I would probably postulate that your response rate will be the same, because the mechanism of antiviral therapy is just different than with interferon. You would think that if there is a role for CD4 count, it's going to be an interferon-based therapy, and that is, in the old days, when we only used interferon alone, there was actually a lower response rate and low CD4 count. But in a DAA-based therapy, I don't really think that plays a role anymore. So personally, I would probably be very comfortable. First, always, because low CD4 count means risk of HIV progression. So the first thing is HIV therapy first. Once controlled, then you can think of hepatitis C therapy.
Prof. Laiwana.
Just to add on something about the lowering dose of HCV treatment. As mentioned, only very few studies have been done, and it's not very successful. Also, actually, most of the drugs nowadays are combined with a single pill. So it's impossible to actually reduce the dose unless you want to cut the tablet into 2.
Okay, mic number 3. This is the last question, I hope.
Thuy Lê from the Hospital for Tropical Diseases in Vietnam. Can someone from the panel or from a representative of WHO here comment about the availability of generically made DAA from India, or any effort to make these DAA more affordable in the developing countries?
Well, so I think the availability of DAAs is increasing very, very much because of the introduction of generic DAA products. So it depends really on which country you're in. If you are in a respective country with low income and there is the possibility of getting generic drugs, the prices have dropped now to around $800 for a full cycle of therapy. So, and obviously this is all dependent on the volume. So the more people are getting therapy, the lower the price becomes. So I'm pretty confident that with the introduction of generics, overall the prices will become much, much lower. I think the biggest challenge is in the middle income countries and in the United States, which is not a middle income country, but in certain ways does become one, because you have restrictions for people who can access the therapy. So if you have, the way into generics, then I think that problem is sort of solved. It's more difficult if you are in a country where, in general, there is a limited budget for health care and there is a sort of enough income that you're not going to get access to generics, and how are you going to do that? And I think that depends very much on the political will and also on the negotiation capacity of the respective countries. So you can see that in Europe, every country has a different price, right? So Germany has the highest price, Portugal has not even the third of the price of the Germans, and then there are countries we can learn from, like Brazil, right? Brazil basically said, we're not going to pay more for hepatitis C therapy than we're paying already with our APACC. So whatever you're going to say, either we're going to make our own fake medication or you're going to negotiate a price which is for us acceptable, but we promise you a great income because we're just going to treat more people. So there are different models, right? So if you can sort of say, we'd treat more, but the prices have to go lower then that may be a way where both sides can benefit. So I think there's a lot of learning now from different countries, how they're implementing that against all these odds sort of high prices. And it's fascinating to see how, if there is someone with strong leadership and strong will, how that is implemented in countries where you would never think it's possible, and whereas in some countries where it would be possible, it's actually not happening because there's no political will, and obviously the community plays a huge role in this all as well. I think there's a comment up front here.
Dr. Yingro might like to comment.
Yeah. I think this is a very important question, and probably the most important question at the moment in many countries. So the generic DAs are becoming available, and in Vietnam also they have become available, but at a higher price than for other countries. So we are looking in WHO in different regions at mechanisms to support pooled negotiations or central procurement. So there are different groups in WHO working on that. It's in the making.
Thank you. I think we come to the end of the session. Thank you to all the speakers for the wonderful talks and all the participants. So thank you very much.